Okay, so thank you everybody for joining and the opportunity to highlight how our multi-sector, so our East Sussex multi-sector pharmacist programme can reduce medication errors during the patient's transfer of care between primary and secondary care. So my name's Alice Conway, and together with Sarah Purdy, we are the training programme directors of this pharmacy multi-sector programme. I'm delighted to have on the grand round today Sascha, who's just actually completed the programme and now working in the locally in the primary care network, and also Josephine, who's one of our current multi-sector programmers, who are going to give showcase some examples of the contribution to patient care. So I'm just checking if I can move on to the next slide. Okay, so we're going to just to highlight a reminder of the long-term plan. So just to kind of focus on the fact this integrated care is a vital component in reducing the number of hospital admissions. And here's the definition of integrated care, which is an integrated health and care system when working efficiently ensures that patients transition between acute hospital-based care and community or primary care runs smoothly and discharges are well coordinated. So the benefits of this integrated healthcare system, you've got this overall holistic view of the patient and their medicines, delivering a greater understanding of the cause and effect of different interventions, hopefully a seamless patient journey, improved networking, so access to specialist, medical, pharmacists, all healthcare professionals, so really improving that network and that community of practice, improving communications and relationships, access to the TCAM data, the transfer of care of medicines data and hospital discharges, and staff supported to continue to grow their clinical expertise. Multi-sector programme in East Sussex, which is hosted by with ESHT. Once pharmacists join the programme, they have a comprehensive core induction, and then they move to one of our partners, whether it's actually one of the primary care networks working alongside in a GP practice, or within the CCG, or working in care homes, or working within mental health, or doing a rotation in secondary care, for example, on the acute medical unit or on the frailty wards. They rotate around these various areas, developing from foundation to advance, and alongside this opportunity to deliver patient care in all these areas of practice, they will be developing supervisory skills, so they'll undertake a practice supervisor course, they'll develop management and leadership skills, they'll undertake quality improvement projects. Key to this is they'll become non-medical prescribers and have a scope of practice that's linked into our service needs, and undertake all these amazing multi-professional learning opportunities, like, for example, we have here on the grand round. The programme, the educational governance around this is supported with a local faculty group and also feeds into the local academic board. And we track the multi-sector pharmacist progress through workplace-based assessments, for example, case-based discussions, mini-KEXs, and 360-degree feedback models. So I'm going to pass over to Sascha to present case study 1.
Hello everyone, my name is Sascha, and as Alice mentioned, I just completed the vocational training scheme and currently working for Bexhill Primary Care Network. So these are all the during the program I completed different rotation, and I was MAU frailty ward, then I went with the CCG with the medicine management team, then the next step was with the care home and medicine optimization team. Then I spent some time also with the primary care network, Sussex Community Healthcare, and also with the mental health team. And I've completed my independent prescribing goals through the program, and my scope practice was DOAC prescribing for prevention in stroke in AF. So if you can move to the next slide, please. So I will just present a case around transfer of care and some of the focus that currently are for primary care networks. Next slide, please. So the primary care directive, there is the directed enhanced service, where the scope is to deliver better outcome for patient regarding to medication. And there's been identified some key indicators regarding good practice for prescribing, and also to look at combination of medication that are known to increase harm for patient. Next slide. So the three main indicators are patient over 65 on non-steroid anti-inflammatory without gastroprotection, patient on oral anticoagulant and antiplatelet without gastroprotection, patient on dual platelet therapy without gastroprotection. So these have been identified as the key areas of people at risk that could be being hospitalized due to gastrointestinal bleed. Next slide, please. So the case presented here is a 91-year-old woman. She was admitted for a fall. On admission, she was diagnosed with AKI, and also she was shown to have atrial fibrillation. She had a history of hypertension, hypercholesteremia. She's got no allergies, no herbal medication, and her medication adherence is fine. On admission, she was on benzofulamide 2.5, doxazosine 4 mg, fedapine 5 mg twice a day, aspirin, ramipril, and simvastatin. Next slide, please. So, on discharge, the benzofulamide was stopped, doxazosine was stopped, and simvastatin was stopped. That was because her blood pressure was quite low, and the statin, I think, was stopped because there was, based on patient age, there was no need to continue the statins. Patient was started on apixaban 5 mg twice a day. Body weight was 86 and creatinine was 95. And ramipril was also reduced from 10 to 5 mg for the patient. Next slide, please. So final discharge, we got now patient on apixaban 5 mg twice a day, ramipril 5 at night, nifedipine twice a day, and aspirin 1 a day. Next slide, please. So this is the general integrated management of AF, and as discussed, it should be all patient-centered, optimizing stroke prevention medication, and also managing rate or rhythm control based on patient comorbidities and risk factors. Educating the patient on management of and adherence of medication, lifestyle, smoking cessation, dietary intervention if you need to lose weight, exercise, and also cognitive behavior if needed. And that should be normally done by a multidisciplinary approach. And then when the patient is transferred from secondary to primary care, there should be a follow-up based on, of any intervention or medication that the patient received during the admission. If we can go to the next slide, please. So patient was transferred and the TCAM system was used. Then we had a communication from the community pharmacy that was suggesting to add PPI for gastroprotection for the patient, as the patient was on aspirin and apixaban. When we looked into it, actually we realized that aspirin was more what we call like an historical prescribing, that patient in the past was started on aspirin as if they had any sort of hypertension or cardiovascular risk, but not on anymore in the current guidelines. And because the patient was started on apixaban, and that will already cover stroke prevention, so the aspirin was actually stopped. And there was also discussion around starting the patient on rate control, and the patient was started on bisoprolol 1.25 mg, and blood pressure and heart rate was monitored with the aim then to stop the nifedipine, as the patient didn't need such a tight control of her blood pressure. Next slide, please. So from a primary care point, when we look at a discharge letter, information that normally are quite useful is when the patient is started on anticoagulant, if the direction, if the anticoagulant has been started for AF, DVT, PE, if the creatinine clearance, body weight are actually indicated, and if the patient has been started on anticoagulation, they should also have a CHA2DS2-VASc score and a HAS-BLET, or now ORBIT. This is the new tool to calculate increased bleeding risk. And if we consider the patient was on aspirin and apixaban, if the HAS-BLET or ORBIT score would be used, it would have highlighted that the patient has a higher risk of bleeding. That normally should have suggested to start the patient on a PPI for gastroprotection. And we can, underneath you got also the link for ESH guidelines regarding that. Next slide, please. So, and this is from the ESH guidelines regarding patient discharged on DOAC, and it actually mentioned that the patient should have a indication duration of the DOAC for AF, CHA2DS2-VASc, HAS-BLET score, creatinine clearance, and body weight. If people are not familiar where to find the guidelines, I think we can send information about it, or you can ask the pharmacy team covering the ward. They should be able to support or the medical team or wish to start patient on the DOAC. Next slide, please.
Do you want to just highlight what because you've been through the whole multi-sector program, Sascha, all the various sectors, actually how this has supported the transfer of care? Yeah,
I think the key point that what I find by moving different sectors about around communication. You know, everyone works in a busy environment, and but if we provide, especially patient with starting or higher risk medication like anticoagulant, if the correct information are provided from the beginning, it wouldn't make much easier than for like a primary care to follow up and make any further intervention. But then if information are missing, then you find you get emails or phone calls from the GP practice asking, you know, for further information, and that can cause a delay on the patient starting a new medication, or even putting the patient at risk of maybe, like in this case, of having a gastric bleeding, especially if you consider it was a patient who was 91 years old and was started on apixaban and aspirin, so it's got a higher increased risk of GI bleed. You know, this is where I think the medical team and the pharmacy team, especially on the ward, can work together. And, you know, if the medical team highlight to the pharmacy team that a patient is being started on DOAC, they can counsel the patient, giving all the right advice, can mention that in the TCAM, so that the community pharmacy can also follow up the patient who has been started on a new anticoagulant. And if all the correct information passed then to the primary care team, we can then pick up the patient, follow up. If you need to book him an appointment in a month's time, you know, recheck renal function if needed, and just check how the patient is actually doing on the new medication.
Thank you very much. Now move on to our second case. So over to Josephine.
Good afternoon, everyone. Hi, my name's Josephine, and I started on the Multisector Pharmacist program in May this year after working in acute for about 5 years in Surrey. I've currently completed my induction at ESH, and I've gone on to do my mental health rotation at the Department of Psychiatry, which is literally next door to EDGH. And I also got the opportunity to work with the community mental health teams. I'm currently doing a split rotation with the community health services over at Irvine unit. And then the rest of my week is at EDGH working with the frailty team, mainly on blind ward. And the next rotations I'll be completing later will be CCG and primary care. Next slide, please. My case study is on a 73-year-old female who was admitted from home to the Department of Psychiatry with depression. Her past medical history is depression, dementia, COPD, atrial fibrillation, type 2 diabetes, ischemic heart disease, and hearing loss. On admission to the Department of Psychiatry, she was on all of these medications. So the sertraline, clonazepam, risperidone were mainly related to her mental health and the depression. The atorvastatin was for the primary prevention. The Steravent and the salbutamol were for her COPD. Bisoprolol was for her AF. Clopidogrel was for the ischemic heart disease. And metformin was for her type 2 diabetes. Lansoprazole was for gastroprotection. Cholecalciferol was for her vitamin D deficiency. Folic acid was for folate deficiency. Cetirizine was for allergy, and then codidromol was mainly to manage her pain. She was allergic to ACE inhibitors and NSAIDs, and she had adverse reactions. However, we couldn't clarify what reactions she got or which NSAIDs or ACE inhibitors in particular she had an allergy to because of her mental illness. Also, adherence issues were identified. However, we couldn't clarify whether she was forgetting to take her medications or if she was having any challenges because she was unwell. The patient was also a smoker, and we couldn't clarify information about alcohol, over-the-counter medications, herbal or homeopathic medications. So within a few hours of admission to the Department of Psychiatry, the patient was transferred to EDGH because of low GCS caused by clonazepam. And the transfer from the Department of Psychiatry to EDGH was consistent. Whilst at EDGH, the patient was diagnosed with aspiration pneumonia, iron deficiency anemia, suicidal ideation, and mild AKI. The patient was successfully treated for all these diagnoses. And the patient was also put under the Mental Health Act during admission because of suicidal ideation. A TCAMS referral was sent as part of the discharge process. And what usually happens is that when a patient is admitted, when the medication history is being completed, a TCAMS referral is done in preparation for discharge. Therefore, it's very important that all the information on the discharge summary is accurate, because this is a very reliable way of communicating with community pharmacists and other healthcare professionals who come across the discharge summary. Therefore, it's very important that information on here is accurate and can be relayed and used by other healthcare professionals. The patient was also transferred back to the Department of Psychiatry later. But when the patient was discharged from EDGH to the Department of Psychiatry, these were the list of medications that the patient came back with. It was great to see that the medications had been optimized, where the patient was admitted with 14 medications from the Department of Psychiatry, and this had been reduced down to 6 over the EDGH. However, the only problem was that some of the medications or some of the changes hadn't been highlighted as to why the medications had been stopped. So here, prednisolone, patient was on prednisolone, 10 milligram, reducing schedule. The reason was documented in the discharge summary, which was great because it made it clear for us over at the Department of Psychiatry to know what happened with the patient. The patient's Cerevan inhaler had been changed to Amoah ellipta, and this had been mentioned. However, there was no mention about whether the patient had been counseled on this or not. And we couldn't clarify with the patient either. The patient was also on risperidone, 2 milligrams before admission to EDGH. However, this was reduced to 500 micrograms twice a day. The challenge with this medication was that in the drug chart, which we luckily got a photocopy of at the Department of Psychiatry, the risperidone had been written up as 500 micrograms once a day. However, in the discharge letter, it had been written up as 500 micrograms twice a day. Therefore, we needed to clarify if this change was intentional or not. There was no change on the patient's sertraline. The patient's lansoprazole had been changed to famotidine because of low potassium, and this change was highlighted in the discharge letter. The patient's codidromol was also changed to paracetamol, and this was also highlighted. So all these medications were omitted or changed whilst the patient was admitted at EDGH. However, there was no reason for these changes documented in the discharge letter, and these medications were not also mentioned in the discharge letter to say they had been stopped or changed, which would have meant that the transfer or whatever letter would have been sent to the community pharmacy would then have had all these changes listed on it for a safe discharge. Next slide, please. Also, the salbutamol and clopidogrel were also not mentioned, and there was no reason or clear indication as to the change that why they would have been stopped. Next slide. So the main interventions, because working as a multi-sector pharmacist, it was really helpful because we've got a lot of networks with the hospital, with EDGH, so I knew which pharmacist to contact. This helped because the great thing about this patient was that it was very clear that medications had been optimized, but the only challenge was that the medications that were stopped were not clarified, and this would have really helped us, especially at the Department of Psychiatry, to make it clear why things were stopped, and to also reduce the time that would have spent asking for what had been changed and the reasons why this had been changed. However, being able to contact the pharmacist at EDGH and the doctor made it very simple, which was a great use of networking, which is an advantage of being a multi-sector pharmacist. We were able to clarify the changes that had been made and why they'd been made. And we had discussions with the doctors at the Department of Psychiatry and reviewed the medication changes. As a result of this, the clopidogrel and salbutamol were re-prescribed, and the risperidone was also confirmed to be twice a day. It still wasn't clear if the patient had been counseled on the Amoah lifter or not. However, this was done at the Department of Psychiatry. The medication changes were also documented on care notes, which is the system used by the Department of Psychiatry. And this will be reflected in the discharge summary when the patient is discharged. A very useful guide to have for discharges, which pretty much gives you a good summary of what to do with discharge letters, is on the micro guide under the doctor's handbook. And this is a very comprehensive list of the steps to follow when doing discharge summaries. Also, pharmacists, the whole pharmacist team is available, so make use of us. We've got our wonderful technicians and everyone on the wards available, so if you have any questions at all, just feel free to ask any of the team. If they don't know, they will very happily refer you to someone who knows to be able to help you with the process. Next slide. So, like I mentioned earlier, involve the whole pharmacy team at the earliest opportunity. So any questions relating to discharge, any medication discrepancies identified, please speak to the pharmacy team. We're here to help. And we've also got amazing independent prescribers who can help to facilitate the discharge process. Some of them are on the stroke ward and in cardiology. And they're amazing. They would happily help you to help facilitate the discharge process. One of them is Ivana, who works on the stroke unit. And also one of the things to mainly highlight, which is one of the main learning points from this case, is if any medications are changed, please let's, as not just for pharmacists, but as the whole healthcare team, let's make sure this is highlighted on the discharge letter and the reasons why this is changed. If any medications are started or amended, they should all be mentioned on the discharge letter and why they have been changed as well. Any new devices such as inhalers or insulins should also be mentioned, and it should be emphasize whether there's been counseling completed for the patient or not. Nerve Center is also a good tool to use to highlight this information to other healthcare professionals as well. And also, patients and carers should also be involved in decisions about the patient's care. In this patient's case, it was difficult to involve the patient. However, whenever possible, everyone should be made aware of changes that have happened during the patient's admissions. And also, the TCAMS relies on us sharing accurate information with all healthcare professionals. So this information, discharge letters during the TCAM process, is transferred to the community pharmacy. So if the information isn't accurate, then the community pharmacy would then have accurate information and would end up phoning the hospital to clarify discharges. So it's important that wherever possible, all discharges have accurate information on them to make it safe for every patient that we see. Thank you very much for listening. Any questions for me, please? No. Great. I'll pass over to Alice.
I'll just stop sharing and just want to say, yeah, please do ask Sascha, Josephine, questions about their case. But also, is there anything else people would like to know about the TCAMS process, the discharge process, the independent prescribers in pharmacy? Anything else? Please do fire away with questions. Could I start then by firing a question to people? Are people aware of the TCAMS process or familiar with it? Anybody like any more detail about it? Has anybody else? I can see it's great to see. Thank you for getting back. Thank you. It's great to see there's quite a large number of pharmacists on the call. Have you got any examples as also how to support the transfer of care of medicine? So we've got examples from Josephine in showing the discharge letters fully comprehensive, and Sascha with guidelines for what to write if you've got a patient on a DOAG. I can see in the audience lots of pharmacists. Any other advice you'd like to share with the rest of the people on the call?
Alice, also to mention, a couple of people wrote they didn't know what TCAM is.
Oh, please go. Sorry, yes, thank you. Please, are you able to explain, Sascha? Would you like to kind of?
So TCAM is what is a transfer of the discharge letter. So it means that a copy of the discharge letter then will be sent also to the community pharmacy. Normally, TCAM will be done by the pharmacy technician or the pharmacist. So patient that normally qualified for that will be patient like on a blister pack, or patient started on, for instance, anticoagulant and maybe need close monitoring or adherence issues. So any patient you may think that it could be a problem in terms of like adherence or compliance with their medication, it will be great to do a TCAM, or if there's been major changes to the medication as well, because then the community pharmacy will also get the right up-to-date medication. And then if they have any queries or concern, they can always ring the GP practice or the ward and clarify, if the discharge letter is not clear, or if there's any concern from a community pharmacy point. So that's why sometimes it is important to spend a bit more time completing the discharge letter with the accurate information. And you can also, I know the process may be vary between Conquest and EDGH. At the EDGH, the pharmacy team is actually involved in the discharge process. So you can always ask one of the pharmacy team to check your discharge letter, so they can may highlight, any issues or if there's thing not clear on the on the repeat medication, then discharge for the patient. That would be my advice. Especially if you got any like junior doctors, maybe new to the trust, not familiar with the system, or if you've got any locums maybe working at the trust on a day, they're not familiar with the discharge system that we use, so they should probably ask for the pharmacy team to get involved at a discharge point.
And just, you know, we're trying to build up our pool of independent prescribers within pharmacy to be able to, again, to facilitate that, help facilitate that discharge process in partnership with you. So the transfer of care of medicines, that process, that's initiated on admission, is that as soon as somebody, a patient walks into the hospital or is in the hospital, Sascha? So right at the start. So which again, it's kind of done at the start, which is why, going back to that community pharmacy is going to be sent a copy of the discharge letter, and it's important that it's really clear any changes, so they're not then having to contact the prescribing team to find out exactly why things were stopped or started, or to ensure everything's being done intentionally.
Yes, that's correct. You know, if someone, you know, normally the pharmacy tech will normally do a medicine reconciliation of any new admission, and that would then normally highlight any discrepancy on, you know, on the drug chart use during the admission, and then the prescribing team can then amend that if needed, or highlight if any changes are being done intentionally, if a medication has been stopped for any reason. I think there's a hands up from Anna-Rita.
Yes, hello, hi, I am Anna-Rita. I am specialist mental health pharmacist at the Department of Psychiatry. So I've been working with both Sascha and Josephine during their rotation. Now, at the Department of Psychiatry, we still don't have a TCAM equivalent, which is in the planning. So I have no data as such before and after in terms of involving the community pharmacists. So if there is a query on a discharge at present, we would hear from the GP, from surgery. Can I please ask, can I please ask what is if you have any number or any feedback on how the community pharmacists are receiving the TCAM, and also the impact which the TCAM is having on pharmacy, hospital pharmacy team workload or input or anything. So in a way, before and after the TCAM. I don't know if I've been clear with my question. Thank you.
So I think regarding the feedback from community pharmacy, I don't think we've got anybody on the call, but I just know Heidi, I know you're doing some, I wonder if you've got any insight out of interest from your experience. I'd like to join in with your experience of this.
I think Heidi's left the call.
Okay, so I guess what we're understanding is actually it's a really essential process. But regarding facts and figures, there's a bit of work been going on, and I think this is probably good to get a conversation with John Farmer, who's leading this for ESHT, as to how this is being received around. It's a really good point regarding how we can actually integrate ESHT and you know and DOP in the TCAM process, because again in Josephine's patient, there were changes made after the you know, when the patient left and arrived into DOP. So the TCAM had already gone to the community pharmacy with that kind of not the whole story about what medicines had been stopped, and we want to kind of prevent that from happening to reduce the you know the challenges of actually having to kind of work out why medicines, what happened to the medicines. So that's a really good point, Anna-Rita, and I think we need to do a bit more kind of working together with community pharmacy to kind of find out their experiences and is it working. Could we do anything different? Yeah. Yes, that's a really good point.
That would be, it would be interesting to have a feedback, on how the service is going and how it is received. And thank you.
We've got again thinking from your perspective again, thinking about patients coming into DOP from EDGH. Any advice to support the discharge process, and also, I guess we've both had Sascha and Josephine working in community health services. Any advice about how to smooth that transfer of care?
Yes, of course, we would do a MedRec anyway, even if it's coming from another trust. And I suppose the reason is, to be extra careful and patient safety. Yes, I would emphasize the need, especially sorry, there is some background, especially during transfer of care within secondary care, never to take it for granted, because sometimes, and we're all busy, and I'm guilty of it, and we all work in busy worlds, but that process is extremely important. And the fact that the patient is going to another secondary care, it doesn't, in a way, that doesn't mean that we can be a bit more relaxed about that, because actually that could be even more unsafe, because the patient is going from a busy ward to another busy ward, possibly during out of hours, when there is just one doctor on call and when things needs to be done there and then. Whereas maybe in community, the timing is a bit different, and the patient has been discharged anyway, so it's okay in a way. But when the discharge happens between secondary care, I would emphasize the need to be extremely careful, because, and this example that Josephine has brought has been a great learning from us as well here at the DOP. And another thing we were debating, which did cause some debate within our team as well, because we are very close to DGH, basically next door. It was easy for Josephine to rush from one ward to another, and because instead of ringing, so we rang, I was busy or something. So, you know what, we need to do it because it's a Friday evening, it's 5:30. We need to liaise with the doctor on call, and we need to understand if clopidogrel, we need to put the patient back on clopidogrel, otherwise it's 2 days without it. So Joseph was like, okay, I'll go there, I'll just try to find someone. And then we said, well, maybe that is too far, because in a way, of course, we can't do it with every patient because it's just unrealistic, but also there is no consistency within the process. We can, because we are next door, but this is not realistic. So it's not a realistic expectation to go and be able to go and go to a different world like this, even between two different trusts, which is the great, and which is a bonus of VTS about contacts, but also at the same time, it is about governance and all that. So I think this was a very interesting case, not just because of what the case was, but also because it triggered some other, some extra stuff.
No, absolutely. I think it's so. I mean, thank you hugely to Josephine and Sascha. Lots of interesting things to discuss. And again, it's that when these things are picked up, they are fed back to prescribers. So again, it's kind of learning from these examples. So I think, is there any more? And that's really valuable points, and it's really great to have you on the call as well, to have that kind of block representation as well. Is there anything anybody else would like to raise? Any other questions? Oh yes, is that a hand up? Oh no, hand. No, I think Anna is that. Trying to see. Dates. No. Okay. Well, in that case, I think huge thank you to Josephine and Sascha. And yeah, great presentations. Thank you, Neera, for your comments about a great presentation. Good to see everybody on the call, and I think we'll let people get back to their lunch hour. And good to see everybody. Thank you very much indeed.